to the next talk, which is by Professor Ajit Babu MAJJI on pearls of surgical management of diabetic retinopathy. Dr. Ajit Babu MAJJI is the past president of AIOS as well as VRSI.
Thank you, Dr. Das and Piyush, and I would like to thank at the outset both AIOS and VRSI for giving this opportunity in presenting in National Symposium. I was asked to speak about pearls of surgical management of diabetic retinopathy. If you see my slide, first slide is a proliferative diabetic retinopathy. Not so much an indication for vitrectomy in diabetic retinopathy. But why I have put it is, immediately after the laser, this patient has developed a combined reg plus tractional detachment. That means there is always a danger that lurks around while you are taking up a patient for panretinal photocoagulation in a proliferative diabetic retinopathy by a general ophthalmologist. So technology has helped us in vitrectomy to revive this patient. But what has happened is a meticulous laser was not done. If the meticulous laser is planned, this complication would not have happened. So prevention is always better than cure in certain cases of proliferative diabetic retinopathy with membrane proliferation while you are taking up for panretinal photocoagulation. This is a preventive measure. Komal has shown several cases of tractional detachment with proliferation where there is laser but seemingly stable retina. But these cases do require early surgical intervention to stabilize the retinal status so that both functional and anatomical stability for a longer run will be achieved after ars plana vitrectomy. So this is also essential. If you see the vision in this patient, it has dropped down by one line, but this vision will remain for next 1 decade or so, rather than if you don't intervene, it will reduce much faster. This is a software engineer with bilateral proliferative diabetic retinopathy with proliferations in both the eyes, amounting for almost like indication for a vitrectomy. If you see the outcome, this is good outcome, 20/30 vision. So again, as I told in the previous scenario, where intervention has resulted in less vision and a stable status, here better vision and a stable status. Both can result with early interventions in proliferative diabetic retinopathy with tractional retinal detachment. This was briefly talked by Dr. Vivek Dave, that subhyaloid hemorrhage in proliferative diabetic retinopathy. Though I thought he will mention about the matter of fact that subhyaloid hemorrhage clinically, when it is in young, it happens, we treat it by egg hyaloidotomy to release it because it is a non-surgical procedure. However, in diabetics, the posterior hyaloid is very thick and it is very resistant to egg hyaloidotomy. So these cases, you should go ahead with a vitrectomy. There, not only we remove the posterior vitreous scaffold, the primary pathology here is the proliferation, vascular proliferation. That also will be tackled, means that will be removed, and a panretinal photocoagulation during endolaser during the surgery will help us stabilize the retinal status. This is the outcome, 20/30 vision from counting fingers, 2 meters. And Komal has briefly touched upon the anti-VEGF use But this I should want to limit for preoperative rather than a regular proliferative diabetic retinopathies. Yesterday in our instruction course, we clearly demonstrated a repeated anti-VEGF injection without surgical interventions has enhanced the fibrous proliferation and the tractional detachment has worsened. However, pre-surgical preparation, if there is a vasoproliferation and a fibrous tissue, the vascularity will come down and the dissection will be relatively blood-free and the dissection can be more complete. So that can be used in cases which are moderate to severe proliferative diabetic retinopathies going for surgery. This patient, this is the first post-op day. You can see it is relatively bloodless. To give that picture, you need to have a relative avascularity in a vasoproliferative process. And when there is severe fibrosis, though Komal, I think Vivek mentioned the proliferation of the posterior hyaloid, the field gets affected. These patients, his vision is 20/60, but if you do the field, severely gets affected. So when you are intervening, his vision improved by one line, but the field will improve manifold. This is from a South Africa patient who is a businessman. While coming into my clinic, he was fumbling to come. And post-operatively, he is free and he started his business again. That's what it does in relieving the fields. Then vitreous traction with recurrent hemorrhages. It's a very simple happening. This patient got 10 times PRP. The patient recurrently bleeding and the treating doctor has not identified there is a vitreous traction. You relieve it. It is a simple vitrectomy, not very complex, but relieve it once for all, it addresses the patient's trouble. This I purposefully kept. This is not even for routine general ophthalmologist. It's not even for early vitreoretinal surgeons. It is for very experienced surgeons because I see so many patients, doctor, you do whatever you like. Because they already heard at several places that nothing can be done, please leave it alone. So these cases, we need to go after them because we cannot leave them blind. So I have taken their worst eye, right eye, and we relieved it. They got 2 meters. They are happy. And the second eye, though it is very severe, better than the right eye, so got 2200. I am the happiest. Always vitrectomy do not mean that it gets relieved and good results. No. These patients, especially I have seen this fibrosis, I don't know about PPD, he may address it. If this sugar perioperative period it's not under good controls, there is aggression of fibrosis where you relieve all the membranes, again membranes recur and the traction worsens. This is what has happened in this patient. And post-operatively, luckily, we removed all the membranes and he gained the vision. And the patient's other eye, because of the fibrosis, the break has really become very large because of the fibrosis only. And I had to do cryo and a lot of membrane dissection and to stabilize it with difficulty. So judicious laser is very, very essential. This is for the general ophthalmologist when you are doing for taking up PDRs for a laser. And simple vitrectomy is helpful in preventing recurrent PRPs in those traction, when vitreous traction is associated. PP with membrane dissection, maybe 60% of the patients you can handle very easily. Anti-VEGFs are really useful when there is a vascular proliferation along with fibrosis. Very advanced PDRs, there are no rules. no procedures, no steps. But experienced pair of hands are very much required in these cases. Thank you very much for your attention.